Hello, good evening once again, and welcome to today's tutorials on diuretics. Basically, diuretics are drugs which induce a state of increased urine flow. These agents are basically ion transport inhibitors, and so they act by decreasing sodium reabsorption at different sites of the nephron, and as a result, sodium and other ions, example the chloride, enters the urine in greater quantity than normal, and they do this alongside with water, which is carried passively to maintain an osmotic equilibrium. And like I've been saying, sodium and water are like husband and wife, where the sodium is the husband and the wife being the water. Wherever sodium goes, this faithful wife follows it. And so we get a lot of water being, excreted out of the body just because it followed sodium. Now, it is important for us to note that there is a balance between the dietary sodium intake and also the sodium which we lose through the urine. Now, if this balance is compromised and there is a greater intake of sodium into the body, yet we do not take enough sodium, and so we have sodium being excessively removed from the body, then complications such as fluid overload may occur. And so you may see symptoms such as edema, pulmonary edema, or even a high blood pressure. Now, on the other hand, when there is a greater removal of sodium, but not enough sodium in the food we eat or the amount of sodium we take, then complications such as fluid depletion may also occur, and so you may see it in states such as renal failure or reduced outputs of blood from the heart itself. Now, after talking about this, let's classify diuretics. Basically, we have two main ways of classifying them. One based on the site of the nephron where they act, and two based on its efficacy. Now, based on the site of action, we have drugs acting on the proximal convoluted tubule, such as the carbonic anhydrase. We also have drugs acting on the ascending loop of Henle, that is a thick ascending loop of Henle, which are basically the loop diuretics, as the name implies. Then we also have drugs acting on the distal convoluted tubule, such as the thiazide diuretics, and also we may have drugs acting on the collecting duct, such as the potassium sparing diuretics. This is one classification. We can also classify it based on its efficacy, how efficacious it is, and based on this we have the high efficacy, the moderate efficacy, and also the low efficacy diuretics. The high efficacy diuretics are also known as the ceiling diuretics, and they are fast or they are quick in action, and these ones are basically inhibitors of sodium, potassium, as well as chloride co-transport of the body. Example may include the furosemide, the bumetanide, and also the toracimide. When we pick the moderate efficacy, they are basically sodium chloride symporter inhibitors, and they are basically the thiazides, and so all of the drugs under this ends with thiazides, such as the hydrochlorothiazide and also the benzthiazide. We also have other thiazides, so we call them the thiazide-like diuretics, and example include the clothalidine as well as the indapamide and exapamide. Then we have the low efficacy diuretics. They are also called adjunctive diuretics because we usually add them to the main, or we usually add some other form of diuretics to them to enhance their efficacy. An example include the osmotic diuretic, the potassium sparing diuretic, as well as the carbonic anhydrase inhibitors. Now, this is a diagram which is depicting the various sites where the diuretics will prevent the reabsorption of sodium and other electrolytes back into circulation. And so over here we have the carbonic anhydrase at the proximal convoluted tubule. We also have the osmotic diuretic at the thin descending loop of Henle. Then we have the loop diuretics or the sealing diuretics at the thick ascending loop of Henle, where they inhibit the sodium potassium chloride co-transport. Then at the thiazide diuretics, we have it working specifically at the distal convoluted tubule, the early distal convoluted tubule. Then we also have the potassium sparing diuretics at the collecting duct. Now, let's quickly go through the mechanism of action of these diuretics. So basically, let's start with the drugs which work on the thick ascending loop of Henle, or the loop diuretics. We have the diuretic inhibiting the sodium potassium chloride co-transport in the lumen of the thick ascending loop of Henle. And when this happens, it leads to the decrease of reabsorption of sodium and chloride, as well as a decrease in the normal lumen positive potential that will, or that is needed to drive the potassium recycling. This will further lead to an increase in the excretion of magnesium and calcium. So this is basically the mechanism with which these loop diuretics work. And an important point to note over here is that they increase renal blood flow, and they also have a weak carbonic anhydrase effect, or they weakly inhibit carbonic anhydrase. Now, looking at the clinical use, or the indication for these loop diuretics, we have them being used in hypertension, acute pulmonary edema, also in edema which is associated with congestive heart failure. Then we also have hepatic cirrhosis, diabetic nephropathy, and also in states where we have increased calcium in circulation, as well as increased potassium in circulation. Now we shall look at these ones in detail. Now, when we pick, for example, its use as being used in the management of edema, we realize that diuretics, or these loop diuretics, specifically the furosemide, are used irrespective of the cause of the edema. We know the edema can be of a cardiac origin, a hepatic origin, or even a renal origin. And so these high sealing diuretics are preferred in congestive heart failure for the rapid mobilization of the edema fluid. You know that thiazides may be used for maintenance, but often they prove ineffective, and these high sealing or these loop diuretics are called in to come and save the situation. And we also know that for nephrotic and other forms of resistant edemas, the high sealing diuretics are the drugs of choice. Also, in chronic renal failure, massive doses of these loop diuretics have been used, and we've really achieved good results. But they also continue to be effective, whilst in comparison with the thiazides, just do not produce any action at all, especially when they are being used in chronic renal failure. Sometimes also we are able to use these loop diuretics in impending acute renal failure. to the extent that we use these loop diuretics to prevent patients from even going in for dialysis. And so they are very good diuretics, and they have very good significance when it comes to the management of edema. We can also use them in acute pulmonary edema and also in left ventricular failure following myocardial infarction. And the intravenous administration of furosemide and some of these other loop diuretics produce a prompt relief in patients who are having left ventricular failure. And they do this basically because of the vasodilation or the vasodilative action that precedes the diuretic action of these loop diuretics. Subsequently, we also find out that they decrease decrease in blood flow or blood volume and venous return is responsible also for the improvement of the pulmonary edema in patients with left ventricular failure. And then we also have it being used in cerebral edema. Now over here, even though the osmotic diuretics are primarily used in the management of cerebral edema, furosemide may be combined to improve its efficacy. Then we may also use it in hypertension. I think I've spoken about this before, but these high ceiling diuretics are indicated only in the presence of renal insufficiency. That we may use them in the management of hypertension when it is accompanied by renal insufficiency, also in congestive heart failure, and also in some resistant cases or hypertensive emergencies. Without these indications, we may want to choose the thiazide diuretics in the management of hypertension. Then sometimes also we give these loop diuretics such as furosemide alongside with blood transfusion in severe anemic patients, and we do this to prevent circulatory overload. We also use loop diuretics when there is hypercalcemia and also renal calcium stones. This is because furosemide and its other agent, or these loop diuretics, increase the calcium excretion and urine flow, and so they may help to reduce serum calcium levels, and to a larger extent to reduce the incidence of hypercalcemia. Now quickly let's look at the contraindications to the use of loop diuretics. So basically, patients with renal failure which is associated with anuria, you cannot use these agents on them. Also these hepatic coma and hypokalemia, you may not want to give loop diuretics to patients who are already having hypokalemia, since these agents facilitate the secretion of potassium from the body. Also in a hypotensive patient, you may not want to give this drug to, since it leads to large volumes of fluid being secreted from the body, which will lead to a reduced cardiac output and also lead to a fall in the blood pressure. So you may not want to give these loop diuretics to an already patient who is having or who is hypotensive, and also in some hypersensitivity to sulfonamides. Now, what are some of the adverse effects of these agents on the body? or what would be some of the complications of these drugs. Basically, we can have on ENT, you may have ototoxicity, and this ototoxicity is usually rare and usually occurs with loop diuretics. And basically, it's due to the increased salt content of the endolymph, and also a direct toxic action of the hair cells in the internal ear, which takes place, and it is believed this leads to the ototoxicity of loop diuretics. Then, when we look at the water and electrolytes, and as well as acid-base balance, we may have hypokalemia taking place, and this hypokalemia usually is as a result of what I have explained earlier. This is because the furosemide leads to the secretion of potassium from the body, and since potassium is leaving the body, it goes along in large quantities, and so it leads to deficiency or deficit of potassium, being the hypokalemia. And this is the most significant problem that we see. It is, however, rare when we give low doses of these agents, but it may be of grave consequence when increased diuresis is induced or on prolonged therapy, especially if the patient is also not taking in enough potassium. Then we may have grave consequences of these hypokalemia. The degree of hypokalemia appears to be related to the duration of action of the diuretic, and so the longer you use these diuretics, the severe the effect of hypokalemia, or the longer acting drugs cause more loss of potassium in the body. And usually patients who have hypokalemia whilst they are taking loop diuretics may complain of weakness, fatigue, and also muscle cramps, as well as some cardiac arrhythmias may be seen. And these are usually the most severe complications. And these symptoms can be prevented or treated by first giving a high dietary potassium intake, or we can even give supplements of potassium to the patients, or we can together give other agents, which are the adjunctive drugs such as the potassium sparing diuretics, so that whilst the loop diuretics is working to reduce the amount of potassium in the the body, the potassium sparing diuretics, as the name implies, will spare potassium, and so it will counteract the effects of the loop diuretics on the body. Now we also have other side effects such as hypercalcemia, and this is basically due to volume depletion, and usually patients may complain of attacks of gout, and these attacks of gout is usually due to hyperuricemia. In the muscles also we may have severe pain and tenderness, as I've explained earlier on, and in the blood we may have transient granulocytopenia as well as thrombocytopenia. Now, an important point I want us to note over here is that these loop diuretics are very strong diuretics, but they have a very weak antihypertensive effect as compared to thiazide diuretics. And so we realize that the fall in blood pressure is entirely dependent on the reduction in plasma volume as well as the reduction of the cardiac output. This is due to its brief duration of action, and as we've seen, it lasts for between 4 to 6 hours. So that is it. A quick word on its pharmacokinetic. They are rapidly absorbed orally, but bioavailability is still around about 60%, and they are partly conjugated with glucuronic acid and also mainly excreted unchanged by glomerular filtration as well as tubular secretion. The half-life is around 1 to 2 hours. Now let's have a quick look at the other forms of loop diuretics. And so we have the bumetanide, and this bumetanide is similar to furosemide in all aspects, but we see that it is 40 times more potent than the furosemide. It induces a very rapid diuresis and is highly effective in pulmonary edema. So when patients come with pulmonary edema, we usually will recommend bumetanide when furosemide is not being effective. And we also realize that it is highly lipid soluble, about 80 to 100% bioavailability when it's taken orally, and it binds to plasma proteins as well, and it's usually metabolized and partly secreted unchanged in the urine. And we also have its plasma life or plasma half-life being around 60 minutes. But this 60 minutes may get prolonged in patients who are having a hepatic insufficiency. And the last one we shall look at is the toracimide, and this toracimide is also another loop diuretic, and its properties are also similar to that of furosemide, yet it is also much potent, about 3 times potent than furosemide. And its oral absorption is more rapid and more complete, and elimination half-life is about 3.5 hours, and the duration of action is between 4 to 8 hours or even longer. And it's also very effective in the management of edema and also in hypertension. So basically this is what we need to know about the loop diuretics. Now let's look at the drugs which act on the distal convoluted tubule, or basically let's look at the thiazide diuretics. And as we've seen, these always ends with thiazide. So we have the benzoflumethiazide, the hydrochlorothiazide. Now, how do they work? They work as we've seen. Let's go back to the diagram over here. They work basically at the proximal convoluted tubule. They work basically at the distal convoluted tubule over here, as we've seen, and they inhibit the sodium chloride co-transport. So what goes into it? So they inhibit sodium chloride reabsorption from the luminal side of the epithelial cells in the distal convoluted tubule, and also to some extent in the late distal convoluted tubule, and this leads to an increased concentration of sodium chloride in the tubular fluid, which results also in an increased volume of urine. Now the second thing we also see is that they also increase calcium reabsorption in the distal convoluted tubule, and this is probably results from the low amount or the little amount of sodium in the cell. Now these thiazide diuretics also cause a direct relaxation of arteriolar smooth muscles, and this leads to the continued hypotensive effect that we see when we give thiazide diuretics. Now let's look at its use, how do we use thiazide diuretics in clinical settings? Basically, we use them in the congestive heart failures, also in some nephrolithiasis, and also in neurogenic diabetes insipidus. In these cases, we may also use thiazide diuretics. Also, we may use it in diabetic nephropathies. Then also we may use it in other nephrosis. So that is it. That's the clinical use of these drugs. Now, before we give much explanation into this, I want us to see the other forms of the drug. We have the clothalidin, or the other forms of these drugs. We have the clothalidin, which is particularly a long-acting thiazide diuretics, and it has a half-life of 40 to 50 hours. Then it is used exclusively as an antihypertensive agent. Then we also have the indapamide. This indapamide is a mild diuretic, and it's chemically related to clothalidin. It helps to reduce blood pressure at doses which cause little diuresis, and also electrolyte disturbances as well as potassium loss are all minimal when we use these form of thiazide diuretic. And so it's very, very effective in post-stroke patients, and also we usually combine it with or without ACE inhibitor. And when we do that, it helps to reduce the risk of further strokes. Then we also see indapamide being used in diabetes, and also in patients with metabolic syndrome. In metabolic syndrome. So let's quickly look at the pharmacokinetics. And basically, it's absorbed orally with its action starting within within 1 hour, but the duration varies from 8 to 48 hours, and so it has a very long time. It has a very long duration of action, and it has very little hepatic metabolism, and also it's excreted by the liver. Now, coming back to the contraindications. It is contraindicated in hepatic cirrhosis, borderline renal failure, hypersensitivity, and also patients who are hypersensitive to these sulfonamides. You cannot give them. Now, a quick one on the use of these thiazide diuretics is that they also are used in edemas. I think I didn't write that one over here. So we use these drugs also to reduce edema, on the management of edema, and they may be used for mild to moderate cases, and also for mobilization of edema fluid. More efficacious or high efficacious diuretics may be preferred, such as the loop diuretics, but thiazides may also be considered for maintenance of these drugs. After we've used the after we've used the furosemide, we can use thiazide diuretics to maintain the effect. Now, the second thing I want us to see is that it's also indicated in the use of hypertension, and it is interesting to know that thiazides are mild antihypertensives, yet these group of drugs, especially the clothalidin, are one of the first line of drugs which we use in the management of hypertension, and they are also the first choice of drugs in uncomplicated hypertension. As I said earlier on, the complicated hypertension are usually we use the loop diuretics, but for the uncomplicated hypertension, it is advisable for us to use the thiazide diuretics. Yeah. Now we also witness that the diuresis reduces the plasma and the extracellular fluid volume by 5 to 15%, and this will lead to a decrease in the cardiac output, as as we've studied earlier on. And since the cardiac output also determines the systolic blood pressure, once it goes down, blood pressure will also come down. Now, interestingly, the fall in blood pressure when we use thiazide diuretics develops gradually over 2 to 4 weeks. And during this long-term, treatment with thiazides, the heart rate and the cardiac output are not affected, yet we may have an effect on the total peripheral resistance, and so the total peripheral resistance will reduce. And once the total peripheral resistance is reduced, the diastolic pressure will also come down. Whilst we are using these drugs, postural hypotension is rare, to be seen. And the average fall in the mean arterial pressure is usually between 10 millimeters per mercury, and so they are effective by themselves in 30% of cases. And 30% of cases of these low grade hypertension, but they usually, or they almost all the time, potentiate all other antihypertensives, especially with the exception of the dihydropyridines. And we also see that they are very effective in elderly. When we use thiazides in elderly, it's very, very effective. Like I said earlier on, they are also used in diabetic or diabetes insipidus. And over here, they reduce the urine volume, and we realize that it is ineffective in renal or the nephrogenic diabetes insipidus. And this is because in this case we see that the kidneys are unresponsive to antidiuretic hormone, but it's active in neurogenic diabetes insipidus. We also have another indication for these drugs in hypercalcemia or hypercalciuria with the recurrent calcium stones in the kidneys. So we give these drugs, and they act by reducing calcium excretion from the body. So basically that is it. A few things on the contraindication of or the complications of these diuretics is that they also cause hypokalemia, and as I explained earlier on, it's almost the same. The roots or the reason behind the hypokalemia is the same as loop diuretics, and so I don't want to go over it again. Then we also have it causing GI, that's gastrointestinal disturbances, and so the patient may complain of nausea and vomiting, and also sometimes diarrhea may occur, and during these times the patient may complain of headache, and sometimes weakness. When we use these diuretics, we may also have what we call hyperuricemia. So this is usually due to the long-term use of higher doses of thiazides, and it leads to the rise in the serum level of urates, and so you may have hyperuricemia. We can usually or always counteract this effect by giving allopurinol. when we give allopurinol, it can counteract this effect. We may also have other side effects or complications such as hyperglycemia, and alongside we may have also hyperlipidemia, and this usually occurred when we use these diuretics in managing hypertension. Calcium levels may also increase, as I've stated earlier. It usually occurs with thiazides. Whilst hypocalcemia occurs with the high ceiling diuretics, hypercalcemia may occur with thiazide diuretics when they are administered for a very long time. Magnesium may also be depleted when we use these agents, and it's usually after prolonged use of thiazides, and also sometimes also loop diuretics may also cause hypomagnesemia. So, and when this happens, it may increase the risk of ventricular arrhythmias, especially after myocardial infarction, or when these patients are digitalized. And we can use these potassium sparing diuretics concurrently to minimize the loss of magnesium. Then finally we can talk about the use of these diuretics in pregnancy. Now, diuretics should not be used in the toxemia of pregnancy, in which blood volume is low, despite the patient having tissue fluid, high tissue fluid, and so you may see edema, but the blood volume itself will be low, and so diuretics may further compromise placenta circulation when you give them, and it will lead to miscarriages, fetal death, and so diuretics are contraindicated. Please note, diuretics are contraindicated in pregnancy-induced hypertension. So in other hypertensive cases, you may use diuretics, but in pregnancy-induced hypertension, diuretics may not be given. So this is the end of today's discussion on both loop diuretics as well as the thiazide diuretics. Thank you very much for listening.